loud naturally, so if I get in front of the mics, you might not like it. So I'll try and do my best to moderate my voice. Yeah, exactly. As Patrick said, I'm a professor at the University of Kentucky in the College of Communication and Information in the Department of Communication. That's kind of a mouthful. And I primarily specialize in media and community-based interventions for risk prevention and health promotion, specifically with adolescents, because I like to work with teenagers because I can't seem to get enough punishment in my life. After every study I work in the schools, I swear I'm never going to do it again, and then of course I turn around and do exactly that. But I also work in an area of physician-patient communication, something I've been interested in for the past 20 some odd years. And those of us who are interested in patient-provider communication or physician-patient, but you'll hear me use those interchangeably, it's really provider-patient communication. Those of us who are interested in that area generally have kind of a reason for that. You know, maybe we've had a bad experience with a physician or with a clinician or with a provider, or maybe we have had a relative who had a bad outcome and the doctor or the provider just kind of stood back and went, nope, I didn't do anything bad here. You didn't follow up, you didn't do this, that, or the other thing. And so it's not really our fault, we're not culpable. And that makes people angry. It makes people feel hurt. It makes people feel betrayed. And unfortunately, it's an all too common experience where, you know, we feel somewhat betrayed by our providers. Now, of course, that's kind of a doom and gloom, dark side approach. There are just as many, really great outcomes as well. But I think we've all had this experience where you've gone to the doctor, or you've gone to a clinician, you've gone to a provider, and you don't feel like they quite heard you. You know, there's the old cliche of the physician with his back to you, typing on the computer the entire time. You know, you're talking to him, her, or he or she's asking you questions. And it's, hard for us to remember as patients that doctors are people too. And they've got, expectations. They're expected to see this many people during the day. They've got to get them through. They've got, used to be, we talked about the 15-minute medical interview. It's not even that anymore. So they've got these pressures. They need to roll people through. And it's hard for us to kind of take their perspective because we're the ones in the doctor's office, right? We're the ones who are sick, hurt, scared, whatever. So it becomes a situation where there's a big power differential. The clinician or the provider has the power because they have the knowledge, right? They get the medical degree, or they have the expertise in rehabilitation, physical therapy, and you're the one who's sitting there with the bum leg, the hurt elbow, the spine or the neck injury, looking for help. And you've got questions, right? You want to know, okay, how long am I going to be in this pain? How long am I going to be hurting? How long am I going to be, basically subverted from leading my normal life? And these are all big burning questions that you want to ask. And the physician, he or she, or the provider, he or she, has got a step series of things they got to go through, right? They have to get in there, they have to evaluate you. Yes, they're going to ask you the same questions that somebody else asked you 10 minutes before, and maybe somebody else asked you 10 minutes before that. By that time, you're kind of frustrated, maybe even waiting for hours. So it's not hard for us as patients to then, basically by the time the physician walks in the door, the provider walks in the door, or the therapist walks in the door, to be frustrated and already starting off, a little bit angry. That sets things up. That could set things up for, kind of a negative outcome. So as providers, unfortunately, there is a bit of a burden on, the provider, the clinician, the therapist, to kind of try and ease that, to try and set that, straight. Because, let's face it. I would say everybody in here, you got into the realm you're in not because you thought you were going to make a whole ton of money, right? I certainly didn't become a professor because I thought I was going to be rolling in the dough. No, it's kind of a vow of poverty. You got into it because you wanted to help people. And as Patrick said, one of the primary ways that providers can help people, one of the primary ways, your primary tool in helping people is frankly communication. Yes, you've got really good clinical knowledge. You have a background, you have a degree, you have, all sorts of training and skills. But you need to have communication in order to get the patient to open up to you, in order to hear what they need to talk about, hear what they need to say. So it helps to start thinking about the patient experience. And when you think about the patient's experience, again, like I said before, you're showing up, you're hurt, maybe you're angry, maybe you're frustrated, you're probably scared, you may not know what's going on. You've probably been through 4 or 5 or 6 different doors before you got to that person, before you got to the clinician. And so there's a bit of anxiety there. And it's your job as a clinician to ask the patient, to find out who the patient is, what's going on, what the problem is, because maybe they were too embarrassed to tell, the other two people they talked to. They were waiting for you to explain what's really going on. So each patient, we have to keep in mind, knows his or her symptoms and body better than any provider, better than any medical test. The patient will know what's going on better than you. They will have not just, a description of the ailments, which sometimes, if you think about vocabulary, can be very hard for people to put in words, to really describe what's going on, to describe how they feel. And I know as providers, it gets frustrating. Because you're asking this person, okay, describe how this hurts, describe what happens here, describe this. And they're not really giving you an accurate description, or you feel like something's not coming across, and you can sense that. And it's not because they're trying to be non-compliant. Many times it's because they don't have the proper vocabulary. They simply don't have the words to describe it. Or, at that particular moment, their anxiety is so high they can't come up with the words. So as providers, it's sometimes necessary to try and help. Okay, so what about this and this and this and this? So we'll talk about that as we go. One of the primary things that we talk about or need to know is to know thyself. To communicate that self to the provider as a patient. And I'm going to be talking from the patient perspective here. Then I'm going to flip to the provider's perspective. So as a patient, because everybody here, you're not just providers of, skill and of medicine and of therapy. You're also patients, right? It flips on a dime. You come down with strep, you come down with this, that, or the other thing, or you get injured, which happens. Because I'm sure most folks here lead pretty active lives. And if you're like me, that means you fall down a lot. You get injured a lot. The folks at UK Sports Medicine know me really, really well. They've been patching me up for years. I still like to run half marathons in my late 40s, and that generally doesn't. Let's put it this way. Robert Hosey at UK Sports Medicine, he and I are on a first-name basis. So I'm there quite a lot. And I'm very familiar with what it's like from the patient perspective, and so are you. But it's hard to remember that, isn't it? You go to your job, you do your job, your daily work, and then something happens, and then now you have to go into the physician yourself, or you have to go into a clinician or a provider yourself. And then it's suddenly switched, and you kind of forget about your perspective oftentimes as a patient. But as patients, we need to make sure we know ourselves and communicate that self to the provider. Because, again, we're the ones who have the description, who know what it is about our disease. Disease is basically identifiable physical abnormalities or abnormal condition in the body. Dis-ease, meaning unease. And illness, disease versus illness. Illness is our experience with that, isn't it? It's a patient's personal experience. So if you think about disease as the physical manifestation, we can think of illness as, well, how do you experience that? Oops, did I move too far? And there are two types of health discourse we basically try to think about when we're looking at patient-provider communication. One is objective language, which is what a lot of providers are used to. It's the language of medicine, right? It's healthcare providers use this. It's the vocabulary. It's the terminology, which within your world makes sense. It's understood. You understand it. They understand you. But outside of that world, it's a foreign vocabulary. It's filled with biomedical information, which many people are not familiar with, may not know the terminology. And it relies on material signs, such as measurable, quantifiable signs of disease. But disease is not just quantifiable, is it? It's an experience. It's something you go through. And as people, we are basically storytellers, aren't we? How do you relay what's going on in your life? You tell a story. How do your patients relay to you what's going on? They try to tell a story. But that kind of clashes with the biomedical model, doesn't it? Which looks at quantifiable, measurable, indicators, markers of disease or illness. So the objective language is kind of the voice of medicine. And in many ways it needs to be, doesn't it? Because you need to know what these identifiable, measurable markers of disease and illness and injury are. But that's not how patients experience it. Patients, tend to use subjective language, which is internal, non-verifiable experiences of illness. So it's not just how it makes them feel, it's how it impacts their life. Most folks are really worried about how is this illness, this injury, going to impact my life? What kind of life changes is it going to cause that I'm going to have to deal with? And the subjective language reveals personal, and cultural health beliefs. As I'm sure many of you have experienced, disease, illness, injury, pain has cultural, differences, doesn't it? People experience pain, people experience illness and disease in different cultures quite differently. In, Western medicine, in Western, basically, if you want to get right down to it, kind of the Anglo-Euro-Western world, we're used to kind of the biomedical, kind of quantifiable, experience of disease, right? Been watching the hospital shows, ER, Grey's Anatomy, all that stuff. Take out the drama, anyway. We've been watching those types of shows, or House. That show's fun to watch, but if you've ever spoken to a physician, especially somebody who specializes in, diseases and things like that, that show House really is kind of the bane of their existence. It was when it was on, because people show up and they expect this house-like team to descend upon them to figure out what the hell's going on. And that usually doesn't work. And the doctors I've spoken to and physicians I know, they're like, you were lucky if once in your entire career you come across something that you can't find like in House and you get to be all exploratory and remember your assignments. Whereas on that show was every week, right? But people had that expectation, that House-like, set team would descend upon them and there'd be some really cool dramatic theme music in the background while they would, set to work on them trying to figure out what's going on. And when that doesn't happen, how do they feel? I'm totally being ignored, and that makes people angry. So there's all sorts of expectations that providers that you have to deal with, that being one of them. And it helps to think in terms of the voice of medicine versus the voice of the life world. The voice of medicine is what providers are used to when you come out in your training. It's the language and the terminology. It's where you have access to empirical observation and tests. You have access to knowledge that patients generally don't. Or if they do have access to it, they don't really have the proper filters, do they? Because everybody can Google anything, right? And if you get on Google, and within 5 minutes, you're pretty much convinced you have cancer. So, but they'll Google all this stuff, and they'll come in, or they'll get on WebMD, and they'll come in with a stack of printouts. I've got a buddy who's a physician, and he says he knows he's in for a rough time when somebody comes in with a stack of journal articles. And you're like, oh, here we go. So you have access to this empirical knowledge, and the web has changed that. But what you have that they don't is the ability to filter that, right? Because as a patient, are you able to objectively read through these journal articles and determine what's going on with your symptomology? No, because you're flipping out, right? Oh my God, I have cancer. Or, I have gangrene and whatever, or especially as a new parent, right? For those of you who have kids, little kids, mine are older now, but I remember when we had the first one, kind of wrapped her in bubble wrap, and we were convinced every time she sneezed, something horrible was going on. Pediatrician was very sympathetic up to a point. I don't blame her a bit. But as providers, you have access to all this specialized information. And the life world may seem irrelevant at times. And do you know what I mean by when I'm talking about the life world? It's the life experience of the patient. It's the world they live in. It's how they're experiencing their disease, how they're experiencing their illness, their injury, their pain. It's not just, the symptoms, such as, my neck hurts, I can't turn, or I've lost feeling in the leg. Maybe they've had a spinal cord injury that's, adversely impacting their mobility and their daily life. It's not just the symptomology of that. It's, well, I can't play tennis. And that's when I used to hang out with the guys. That was my time outside of the house. That was my exercise. Well, I can't do that anymore. I can't do that right now. When can I get back to playing tennis? Or when can I go fishing again? Or when can I go hiking, camping, whatever? They're concerned about that, aren't they? Whereas it's that double, bind. You're concerned with, okay, I need to know exactly what hurts and where, how often, and then we need to run these tests to see what we're finding. So by its very nature, you have to think separately. But in order to reconcile these two, it's a difficult spot to be put in as providers, because you need to be able to have that access to the empirical knowledge and look at that, and yet at the same time take into account the voice of the life world of the patient, recognizing they experience all of this not just as an objectifiable, quantifiable, measurable ball of symptoms, but in terms of the impact of their lives. Disease may be uncomfortable to discuss, for patients. They may not want to talk about it or even think about it. Have you come across, patients or clients who simply didn't want to talk about the big picture? They seem to be afraid of it. It's kind of common. My wife refers to it as the ostrich, sticking your head in the sand. And I don't know if ostriches really do that. I think that might just be a cliched cartoon thing. My wife's a mental health therapist, but she has to confront that all the time with her patients. Those who don't want to discuss the bigger issue. And for the patient, they know they are sick based upon how they feel. Not just they don't look, I have a temperature of this and my heart rate is this, and no, it's how they feel. I know something's off. Have you heard that before? Something's off. Okay, well, can you explain that a little? Well, I just feel off. And that's what I was talking about. Maybe they don't have the vocabulary to accurately describe what's going on. That can be difficult, can't it? And it's your job as provider to try and tease that apart. Okay, what do you mean by off? Specifically, what part of the body feels off? Or, do you feel flushed or something like that? And that's some of the ways that you can help, is by providing those descriptors. Do you feel like your heart rate's off? Do you feel a little lightheaded? Do you feel dizzy? Do you feel this, that, or the other thing? And by going through that, you might be able to provide them with some of the descriptors that they're missing. The rub is that all of this takes time, doesn't it? Time you generally don't have. Because you're kind of expected to roll people through, right? And if you get backed up, by the time you get to that person who's been waiting an extra 2 hours, they're not happy, are they? So it's kind of a bind, but it can be done. And for the patient, the idea of medicine may be overwhelming. Like, I'm the first to admit I hate hospitals. Granted, I show up to hospitals for meetings and things like that. I have a grant funded by the Center for Clinical and Translational, CCTS at UK. So I'm at the hospital for meetings quite a bit. But that's okay, because it's meetings. However, if I'm there, either as a patient or as a family member, or relative of somebody who's a patient, it flips. It's like, the walls are closed. I don't like this place. I don't like the smell. I don't like anything about it. And a lot of people feel that way. Because what do we associate the smell of hospitals with? Death, right? I mean, it's a disinfectant smell, but we associate that with death, with pain, with suffering, with frustration, with anger. So all of these, combine to form that person's experience. And to the extent that you can kind of keep that under concern, you keep that on the, at least on the tip of your tongue, on your mind, it will help you to kind of empathize with the patient. And you can't empathize with the patient and try and understand them without taking too much time. It's, snapping out of a routine. And granted, I know that's hard, because let's say you've been on your feet for 10 hours. You're tired. You're frustrated. You want to go home. Maybe you haven't eaten in like 8 hours. Pretty common? Everybody's like, yeah. So it takes a little effort on your part. But if you flip the coin, if let's say you feel that way, but you go in, you meet with a patient, you meet with a client, you work with them, and then you have a positive outcome. That kind of energizes you, doesn't it? You helped somebody, and you can tell they feel better, they're happy, which makes you happy. Isn't that kind of why you got into this in the first place? So it's important to try and keep all of that in mind. One of the concerns of the physician in the voice of medicine is they're really interested in trying to discover a cause and a cure for the illness or the disease or the injury, right? They're focused. There's a task, and they're focused on that end goal. And oftentimes it's difficult for them to listen to the story, right? Because how do your patients tell you what's going on? Do they always give you a list of symptoms? Or do they start out with, well, okay, I was, hiking in the gorge, and they start with a story, right? or I was going down the stairs or something like that, or my mom was coming over and we were making dinner, they start with a story. And you're like, oh boy, here we go. However, it's important to not shut that down. Because as people, and I'm sure you do this too, when your physicians ask you what's going on, you need to tell that story, don't you? It helps you to organize what's going on in your mind. So it's not just them trying to take your time and be difficult. It's a thought process, a cognitive process we go through to organize what's happening. Because it's happening to us in our lives, right? It's not, a printout on a computer of symptomology. It's how, it's what's going on with you. And the story, the narrative process, is how people make sense of these things. Your patients aren't going to be able to accurately describe to you what's going on, most aren't, without being able to tell their story. Because that's how they're making sense of it. That's how they're organizing it. And if you let them tell their story, now granted within reason, I know some folks will go on forever, right? But if you let them tell their story, let them get started, let them get rolling with it, and maybe ask questions while they're telling their story, but don't interrupt, it helps them to better organize their thoughts, organize what's going on, and then you'll actually get better data at that point. One of the other concerns physicians have, providers have, is trying to describe what's going on in the language of the patient, right? Because you've got your terminology, and this is a rehabilitation group, right? So there's folks here from orthopedics, from spine and neck, and all over. So you've got specific terminology for parts of the body that really people outside of your world don't know, do they? So it's very easy to slip into describing this and this and this and this and this using medical terminology. Now, if your patient or your client is a physician, that's going to work out pretty well, isn't it? However, what if they're, a 75-year-old, farmer from Clay County? Are they going to understand that terminology? And are they also going to stop and ask you questions very often and let you know that they don't understand? Not as often as you think. So that patient may leave that office going, I have no idea. I have this printout. All I know is I'm still hurting. I've got these medicines. I don't know what they're for. And so I don't really know what to do here. To heck with it. I'm not sure how to follow this. And so you'd be surprised how much patient noncompliance, and I'm not sure what the buzzword is these days, because noncompliance was, an insensitive term, and then they wanted us to use something else, but I still call it noncompliance because that's kind of what it is. You'd be surprised how much noncompliance isn't based on the patient trying to act out. It's based on simply not understanding what they're supposed to do. And giving them, a printout of stuff or giving them a couple booklets or flyers isn't gonna do it. You need to take into account who your patient is. I mean, what do you know of them? If this person's a physician, you could probably describe it in medical terms and be very efficient. If this person is not, let's say they're a middle-aged factory worker from Woodford County, works in the LED or the fluorescent lighting plant out there, you're going to have to use a little different language, aren't you? So it's keeping things like this in mind, in terms of what you would describe. That helps. And one of the main concerns patients have is fear. They're scared. And understanding, like I've been talking about. They want to know what's going on. They want to understand, but there's a language barrier. And there's a goal barrier, too. You're focused on figuring out what's going on, prescribing a treatment, getting them out the door, moving on to the next patient. That's not to be insensitive. That's the job. Whereas the patient is, okay, I need to be helped. Or, I want you to fix me. Have you gotten that before? Fix me, please. I just want to be fixed. If they don't say it outright, and that's a whole different kind of ball game than the patient who wants to come in and work with you collaboratively. And a lot of this is based on age differences too. Younger patients, folks that are y'all's age, even up to my age, we have a little more medical knowledge than, say our parents did, than the boomers do. So we might come in with a different knowledge base than, a 73, 75-year-old baby boomer. And so we have to take that into account when we're talking to them. Okay, who is this person? Shake myself out of, my routine here and let me look at this person. What does he or she look like? Where is he or she from? Is there a common ground I can, gain with this person here? And once you find a common ground on something, and it doesn't take very long to do this, you can start to then communicate more effectively. We can think about our health-shaping identity, and granted, I know I'm going to throw out a few theories here at you, but I'm not going to really drill you into them. And no, you're not going to be tested on them, so you can just smile and kind of follow along. But it helps with kind of the overall conversation. We think about social identity theory, which does anybody have any familiarity with that at all? Probably some of you, I imagine, did. Maybe in your early comm classes or your psych classes. But we think of social identity theory when we talk about how our self-concept is affected by our affiliation with certain groups. That's how you identify with yourself, isn't it, right? Your self-concept? You all identify as rehabilitation specialists in one area or another. That's a big core of your identity, isn't it? I may be Roger, or I may be, Don, or something like that. But really, part of that is what groups you identify with. Who you're part of. You're a provider at this clinic. That becomes your identity, or part of your identity. So we need to think about, how does one's identity affect how they participate in their healthcare? It affects quite a bit. If you're a physician and you're going to seek treatment for something, that's going to impact how you work within the system. If you're not, if you're a school teacher, if you're a physical therapist, that's going to impact how you seek and how you participate in healthcare. You'll be more involved, won't you? You'll be more interactive. As rehabilitation experts, as physicians, as providers, when the tables are turned and you're going in, you're a little more interactive and participatory with the provider, aren't you? But not everybody is. And it's, simply, some of it is cultural. There's power differential, and maybe folks have been taught, the physician is of high status. I am not of that type of status, so I'm not going to question what the physician says. I'm not going to, second guess the physician. I'm going to accept what they say because of this status differential. That is a very common thing. And unfortunately, what that leads to is the patient or the, not asking questions, right? Or not being as involved, being a passive, participant in the experience. I'm going to sit here and let you fix me as you know best. But that can be frustrating as a provider, right? When you want people to participate. So there can be that dichotomy, there can be that, conflict there. And how is one's identity affected when they are sick or have a health condition? I also know plenty of physicians who are the worst patients ever when they get sick. Because they, I'm a doctor, they go in to see a physician, or at least it's somewhat reassuring that in UK, the doctors and physicians have to go through the same healthcare system that the professors do, that the faculty and staff do, but we hear the same kinds of things from them. Yeah, when I'm a patient, I'm the worst patient ever because, I want to see my doc, but I can't get in to see him or her, so I see a PA. However, I'm an MD and they're a PA, so I have to go in and see them, and they're 15 years younger than me, and the whole time I'm thinking, I have shoes that are older than you. And so they're not the best patients. Illness changes everything. And what can happen when you don't want to belong to a certain group in terms of your identity? Maybe you don't want to be known as a cancer patient or as a cancer survivor. Or you don't want to be known as a diabetic. And especially for young kids, this identity can be, we all like to think of the situations where somebody embraces their illness identity and use it for good to then be a force of change. That looks great on TV. But most folks are like, yeah, I got other stuff to do. So I don't want to be known as, the cancer patient or the cancer survivor. I had a grad student when I was a professor at Wake Forest, and she was a leukemia survivor, childhood leukemia. And she said growing up, she was known as the cancer kid, and she hated it. So as once her leukemia went in remission, and she was older, and she moved out of the area, she never told anybody that she had, she was a leukemia survivor. because she didn't want to be known again as the cancer kid. So there are, identities that maybe we don't want to embrace. Maybe you have hepatitis C, and it's not responding well to the new treatments. So are you, who are you? Are you, William, or are you the hep C guy? Are you the diabetic? Are you what? And we don't always want to embrace these identities. There are 4 types of post-diagnosis identity, which is important to think of when you're especially with folks who have, serious, injuries, like maybe spine or neck or something like that, that can be permanent. And, it's not really a matter of how to, improve so they go back to their normal daily lives. It's how to help them adjust to a new normal. 4 types of post-diagnosis identity. One is engulfed, which I'm sure many of you are familiar with, where illness becomes an overwhelming priority and takes over one's identity. And we can go through these in stages, with a new diagnosis. So engulfed is, you're just completely wrapped up in it. Resistant, where you try to place disease as not that important and not wanting to admit its effects on one's life. You just try to ignore it. If I ignore it, it won't bother me, it won't impact me, and I can just go on about my life. And detached, where the person rejects or denies it's even happening. This is the ostrich thing I was talking about, the head in the sand. Now that I've used that metaphor twice, I'm actually going to go look that up and see if these stupid birds actually do this. I don't think they do. I think it's like a cartoon or TV thing, but I'm going to find out. Detached, the patient rejects or denies illness and doesn't admit the reality. Versus empowered, which is where we would all like to be, right? If you've got like a major diagnosis, a major illness, some sort of injury that has changed your life and changed it permanently, we would all hope we would, become empowered, take it full force to maintain a positive attitude. Again, looks great on TV, doesn't it? Makes for a good mini-series, makes for a good 30-minute, sitcom. But in reality, how often do you ever see that? I would say most of us tend to flip back and forth between some of these or all of these, depending upon, how it's impacting our life. So when we think about illness, and we think about identity, we think about the voice of the life world, the voice of medicine, it's important to, remember that medical encounters are often dominated by the voice of medicine, especially in the clinical setting, right? Hence the clinical setting. That's where, you need to gain the information. You need to get the test results. You need to do, this, that, and the other thing to find out those measurable, observable, quantifiable markers so you can know what's going on as a clinician, as a provider. But it's also important to remember to listen to the voice of the life world. Because without that, you're going to miss data. You're not going to, if you don't allow people to tell their story, you're going to miss some important things that may impact their treatment, that may impact their diagnosis, that may impact their recovery. One way to accomplish all of this is through patient-provider or patient participation. Ask them questions, get them involved. Younger patients tend to be more participatory, right? And I'm generalizing here. Somebody in their mid-20s is probably going to be will participate more than somebody who's in their mid-60s or mid-70s. And it's a generational thing. But that doesn't mean you should just simply go with that. Because you need the input, right? You need the information from the older patient or from the patient who's reluctant to talk. So we need to encourage that. And it's not all on you. This is not, patients need to step up. They need to become more involved. Some are, some aren't, some are a little too involved. But it's not all your responsibility. So patients do need to step up and be involved. And that's why patient education has become a big thing. Trying to teach people, to educate people that you need to be an active consumer of healthcare, not passive. Some of the common items in patient participation: collaboration, involvement, patient empowerment. All these fall under patient-centered care. I'm sure you've heard that. It's a buzzword. Patient-centered care is probably something that's been kicked around since you started school. All the way through patient-centered care, patient-centered care, patient-centered care. It becomes kind of a buzzword, kind of a mantra, it's that, and it's more than that. Patient-centered care is related to decision-making. Self-medication, self-treatment plans, self-monitoring, patient education, goal setting, taking part in physical care. And when you don't listen to the voice of the life world, things can get missed. A study I conducted about 17 years ago, I was looking at diabetics in Appalachia and in Kentucky and East Tennessee, asking about compliance with their self-treatment regimens. And we were doing telephone interviews and in-clinic interviews, and I'll never forget this. Came across this one very sweet old man who was in a wheelchair, who was missing basically his right foot, halfway up his shin, and was on an insulin pump. But he's a very sweet old man. And while we're going through this interview, talking about self-treatment regimens and his compliance, and he said, I try and do everything the doctor tells me. I follow this, I look at the charts, and this man said he'd also never finished, hadn't finished elementary school. So he didn't really have a vocabulary. And as all this is going on, I came to the realization, and then I asked him about this, that he misunderstood what the purpose of insulin was for. So he was doing the opposite. He was taking insulin when his blood sugar was low and causing lots of problems, had to put him in the hospital, and he wasn't taking it when it was high because he misunderstood what the purpose of his insulin was for, and he'd been doing that for decades, and that led to all of these other physical problems. Once the insulin pump was installed, then it really wasn't that much of a problem for me. But he could have avoided all of that. Decades, at least 20 years, he did not understand the purpose of insulin because he didn't ask the provider. And the provider, they'd given him pamphlets. Okay, you have diabetes, you have type 2 diabetes. Here's some flyers, here's some handouts. Come back and see us. He couldn't read them. He tried, he didn't understand what was in the flyers. But he was too embarrassed to ask questions. So that's an extremely dramatic example, but it is an actual example of what can happen. And at that point in the study, I'm like, okay, I've got to stop. And then, I contacted UK and contacted the IRB. What do I do here? And they had me break confidentiality and talk to his physician. But it was kind of too late, wasn't it? His foot was already gone. He was on the insulin pump. He was in a wheelchair. He was already going blind. He was in bad shape. And he wasn't expected to last a whole lot longer. So the voice of medicine and the voice of life, or the voice of life world, are both equally important. You skip one, you miss something on both sides. So it's important to remember the patient's story. Think about patient participation and the role of the patient. In every relationship, of course, here's the clicker. What, does it work? Oh. I don't normally use these, but now I have a toy. Ooh, and it's got a laser. So I can zap people. No, I won't do that. So in a relationship, there's a negotiation of roles, right? In the clinical encounter, the roles are pretty well set, right? You're the patient, I'm the clinician, the physician, the provider, the therapist. So we have our roles. Some of the old models, the Marcus Welby MD, of course, that's probably an example most people won't get. Those are a little older. But some of the old medical TV shows where it's the all-knowing, somewhat omniscient, father figure doctor with the gray hair, kind of the silver fox look. Where he knows best, and the patient's going, oh, thank you, doctor. That whole thing. It doesn't really happen. That's kind of the old paternalistic model, kind of idealistic, where the doctor's in charge and the patient is passive. It's been changing, right? Due to humanistic approaches, due to television for one, patient-centered care consumerism, we tend to have more informed patients. We also tend to have more misinformed patients, right? There's two sides to that. Because again, WebMD can cut both ways. Not all patients are the same. Research suggests that increasingly patients want participation, albeit there's education and generational differences. So it varies by patient. We want participation, but we want it on our level. Like me, when I go into a physician, a therapist, and I've been through plenty of physical therapists for my various mishaps, I'm actively involved because I want to do whatever it takes to get my elbow fixed, my knee fixed, my leg fixed, my whatever fixed. When I fell down during the half marathon in Louisville and wiped out gloriously, so that I can get back up and start doing whatever again. But others, maybe not so much. Maybe they don't want that. Maybe they want to be more passive. And it's a negotiation of roles, isn't it? If somebody wants to be more passive, you can actually make them angry by trying to force them to be more involved. Have you ever come across that? Some of you have. So it's a negotiation. How much do you want to be involved, how much not? And all of this is kind of a delicate dance, but it doesn't take as long as you think. So this is, a guide for patients here, the Joint Commission on the Accreditation of Healthcare Organizations, and I think this is a handout somewhere, has this thing, you can hand this out to your patients, hand this out to your clients. And it's an acronym, of course, because everybody loves acronyms. Speak up, pay attention, educate yourself on your diagnosis. Ask a family or a friend to accompany you. I think that's critically important, to ask a family or to have somebody accompany you. If you're freaked out, a lot of people do this. If you're freaked out, have somebody come with you. They will remember what's going on. Has anybody in here ever had surgery before where you were knocked out? Yeah. Do you remember anything they said to you after you got up? Now, they told you lots, right? But it's kind of like Charlie Brown's parents. Wah, 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 wah. And you're laying there thinking, Vicodin's knives. You don't remember a dang thing. So it's important to have somebody there. Like, I never remember squat after various and sundry elbow and knee surgeries. But my wife does. She's the one writing it down. She's like, you're not going to remember a thing. You're still cracking jokes. So ask a family or friend to accompany you. Know what medicine to take. Use accredited healthcare facilities. And participate in your care. Final one's so important. Don't be passive. Participate. So essentially, illness and disease are different ways of thinking about medical delivery. This is so much nicer. Having a little thingy. The patient's experience with their health and how it affects their identity must be a part of healthcare. At UK, these things always disappear, or they're stolen, or they're broken. So I just don't even look for them anymore. I wonder if they buy my money. What kind of dig this? Have students sleep in the front or on their smartphone? I think that now. I'm probably in trouble for that. Patients' experience with their health and how it affects their identity must be a part of healthcare. It absolutely must. In order for healthcare to succeed, their story needs to be known. Because otherwise, if they haven't been given a chance to tell their story to somebody, maybe it's not always the physician, right? If the physician has, stacked up patients, maybe there's a nurse who can hear the story, who could then pick out the important parts and relay that to the physician. Somebody needs to hear the story. Somebody who can then help translate that information. Patient participation is a way we can do this, the way we can improve this. But there's the rub. How do we encourage it and still get our jobs done efficiently? So about the provider's perspective, I've been talking about the patients, right? How are you doing on time? I'm doing all right. We think about communication competence. And we've all come across competent communicators and incompetent communicators, right? Oh yeah, I'm sure you have some in your family. I know I have in mine. In fact, I'm probably the incompetent. Just because we study communication and message design and how messages impact this and that and the other thing, doesn't mean we're very good at it. Common measures in research, and I'm going to give you some stuff here just as an illustration. Traditionally, we study communication competence, We presume 0 incompetent, 100 competent, and there's a sample of an instrument. I'm not going to ask you to fill it out. For illustrative purposes. And when people take measures like this, we can determine based on, whether they're communicatively competent in different contexts, whether public speaking, whether in a meeting, which is a smaller group, or whether in an actual group, or a dyad, which is two people, or with a stranger, or with an acquaintance, friend. There's all sorts. And you can compute subscores, and you can find out where is my, how am I communicatively competent? Okay, but all of that's neat and cool and dandy and stuff. But in the healthcare context, it's kind of a different ballgame, right? So we need to think about it differently in terms of the communicatively competent provider. And I'm going to give you some results of a study here because I think you might find them rather interesting. I'm only going to cite one study. I'm not going to throw a lot of stuff at you. I know, Professor. I love to just throw stuff at you, but I'm going to. So we're looking at the communicatively competent provider and the communicatively competent patient. How best we measure these things? Okay, one way is we can look at their perceptions of each other. There's been several studies. I'm going to cite this 2004 study. It's a little old, but it's still relevant. And the ones that have come after it are finding the same thing. One of the best ways to measure it is to ask their perceptions of each other. So the patient, what do you think of the doc? The doc, what do you think of the patient? And then we compare them. What did the doc do well? What did the patient do well? What should they have done? What do you want them to do? And we compare these things, and you'd be surprised what the results are. So there's this one study, Don Segal had a questionnaire following a medical interview, actual medical interview, and both providers and patients were reporting their, the perceived communicative competence of the other, right? There's some bias. Some of the research questions: what makes a competent patient? Do patients and providers agree about what makes a competent patient? Do patients and providers agree about whether patients do these things? And do patients and provider judgments of patient competence affect the patient's set? All right. I know. You go like, oh, God, show me freaking research questions and stuff. It comes, it'll pull us. Work with me. So some of the 4 questions concerning patient, provider, and physician, and why did that number look like that? Okay, I'm going to ignore it. Rate your own competence, describe specific aspects of behavior, rate the other, describe. Okay, simple methodology, right? So what makes a competent patient generally from the patient point of view? Kind of what we think, right? Information provision, asking questions, preparedness, task-oriented, focus on the messages. What makes a competent patient generally from a provider point of view? The same thing. This was a large study. There's a 94% overlap. So providers and patients generally agree on what makes a competent patient. So research questions too. Do they agree? Yes, there's a 94% overlap in terms of, from the patient perspective, be prepared with an agenda, right? Know what you want. But that's hard to do, isn't it? When you're hurt, you're sick, you're in pain, you're freaked out. Coming in with an agenda is a difficult thing. Okay, I'm going to write out a list of questions. I'm going to have all. That'd be great. But oftentimes we're like, I feel. When you've got the stomach flu, are you really thinking about an agenda? Nah. You're focused on other things, aren't you? Yeah. So be prepared with an agenda, but then, give the patient some symptoms. Provide a detailed history of condition and symptoms. And patient perspective, ask questions. Still, there's 94% overlap. So looking at the data, how much did they agree on the occurrence? Okay, so they agree the same things are important on both sides. Well, how often does this happen? It doesn't. In this large study, they found that, yeah, we agree on what makes her a competent provider. We agree on what makes her a competent patient. We agree on the communicative behaviors that define these. How often do these behaviors occur? Infrequently. And there's a disconnect here, right? Looking at the actual discourse, the actual conversation, what people said, did the patient actually demonstrate what patients and providers can continue or consider competent communication? Nope. So patients generally know what they need to do, right? But they don't do it. And it's not because they're being, defiant. My wife would call that oppositionally defiant. She's a mental health clinician. It's because of the context. You're sick, you're hurting, you're in pain, or you've been through like 4 different triages or something like that. You filled out the same questionnaire 4 times, and you're frustrated. So all that goes out the window. What that means, though, is that since we agree on what needs to happen, fairness is good, information seeking, competent communication is not occurring. So unfortunately, because of this disconnect, as providers, you kind of need to nudge them. Kind of need to get them back on here and to think about, okay, why are you here? What do you need? There are all sorts of questions you can do more eloquently than that. What it means for providers, communication becomes a core clinical skill. Generally, a doctor performs 160,000 to 300,000 medical interviews during their career. That's a lot of sit-down, 15-minute medical interviews. I think now they're 10 minutes? Not even 15 anymore? And communication is increasingly making its way into medical curriculum. There are 3 general communication competencies we can think of in provider-patient communication. The Accreditation Council for Graduate Medical Education has come up with these, and they've had experts read through these and identify ways to teach. So what are these competencies? 1, create and sustain a therapeutic and ethically sound relationship with the patient. Use effective listening skills to elicit and provide information using effective nonverbal, explanatory, questioning, writing skills. And you're thinking, oh my God, this is kind of a list. But where studies have gone in, where we've gone in, we trained providers how to do this, it doesn't take any more time. It works within the existing medical interview time. It's just a different way of going about it. Work effectively with others as a member or leader of a healthcare team or professional group. So those are the competencies. And how these competencies are enacted with their patients takes skill. You're not really taught how to do this. How many of you had like an actual on the ground, other than, they're not called test patients. What are the professional actors who serve as patients? You know what I'm talking about? Can't think of the term for that at the moment. But anyway, other than that, have any of you had coursework where you've actually had to go in and work on your communication skills with patients? Yeah, I see one hand. So it doesn't happen very often, does it? You're oftentimes kind of graduate, you've got your degree, you've got your certification. Have at it. Good luck, sport in life. So you're tossed into the mix with this voice of medicine in your head, right? Isn't that what's been beaten into you for the past umpteen years? Terminology, vocabulary, set of clinical goals and procedures, clinical hacks. So, and then you're stuck in a room with a person who wants to tell you a story. And you're like, I wasn't trained to listen to stories. I don't know how to do this. And it's right, because you haven't trained to do that, have you? And by its very nature, medical education has to be very clinical, doesn't it? So you're kind of stuck in there, stuck in this room, and you're oh my God, I don't know what to do here. So you fall back on what you know, right? Because that's where you're comfortable. So how would we work? Yeah, I know this is a big, funky model. We love models. You can think about communication in terms of an ecological model. No, I'm not going to pick this apart, because I'm not going to put it on your exam. There is an example. Yeah. So we think about some of the predispositional influences. We're looking at an ecological model of communication, which looks at the entire experience, right? We can look at communication in organizational context, legal context, cultural context, the media context, and how that interacts with the healthcare provider and the patient. Some of the influences here. We all have communicative predispositions, right? Reflected in one's style of individual communication, and we all have predispositions in terms of how we communicate based on context. When you're out with your friends on a Friday night and you're going to the, bar, Buffalo Wild Wings, something like that. I've been married for decades, so I don't do anything fun anymore. Whatever you young people do for fun, when you're out having fun, you're going to communicate with your friends differently than you do when you're in the clinic, right? Different terminology. Some of the examples, dominant, open, expressive, attentive communicative styles. And our communicative styles are often influenced, by objective. Somebody's age, their sex, their education, and by the subject, their self-concept, features of self, and the socialization. All that impacts how we communicate. Because we all go into a communicative situation with our own biases, our own predispositions. We're a product of where we grew up, right? We're a product of our training, a product of our education, a product of our family life. All that stuff impacts how we communicate. The patient's coming in with the exact same types of predispositions. Not the same as yours, but all those different influences on how they communicate. And somehow, you have to make sense of all that. Some of the dispositions that doctors have, whether they're a doctor-centered or patient-centered physician, whether they're male or female, gender absolutely impacts that. Their beliefs about health, their political ideologies, and their communicative competence. Physicians and providers are people too, and they make assumptions about individuals when they step into a room. It kind of sucks, but everybody does it, whether you admit it or not. You make assumptions about people when you step into a room based on age, race, unfortunately, sex, their education level, whatever information you have in their charts. We make assumptions. This person's a diabetic. He or she are looking at their, test results there. They're a non-compliant diabetic, so this one's going to suck. Okay, so I'm going to go in there and I'm going to be, you start off the medical interview already with a bad predisposition towards it because that's not fair, is it? You don't know the story. You don't know what's going on. You don't know why they're a non-compliant patient. Another example from that diabetic study I did, 16, 17 years ago. I met with an older gentleman who knew everything what he was supposed to do, right? He had everything, he knew exactly what he was supposed to do in terms of foot care, his self-treatment regimen, all of that. But his sugar levels were off the chart. And I asked him, so what's going on here? Why aren't you able to then do this? You know exactly what to do. Well, I don't know how to cook, and I live with my son and daughter. Or I live with my son and daughter-in-law, and she does the cooking. And she doesn't know how to cook, or doesn't want to learn how to cook for somebody who's diabetic. So he's eating a lot of biscuits and sorghum. Because that's what she's making. He wants to eat more fruits and vegetables. He wants to go out and walk more. But he can't because he lives basically glued to the side of a mountain in a holler, and there's no place safe for him to walk. So he knows what to do. He wants to do it, but he can't because of his context. And if you're not engaging or letting him tell his story, you wouldn't know that, would you? You would just see the charts and you'd be like, oh, this he's not going to do what he's supposed to. I don't know why I'm going to bother you. So it's that voice of life world which is important at that point. That's the story. You wouldn't know that unless you heard the story. Versus the patient influences. Education, male or female, age, personality, health literacy. These look pretty similar, don't they? Some of our cognitive, meaning, mental, and affective, meaning emotional influences. Communicators, we generally have a cognitive map, of the encounters with that guide our behavior, what we expect based on past experience. Our perceptions. We have strategic goals, we have attributional goals, relational goals, and, in terms of what our overall goals are for patients, motivation to speak up, empathy, competency, trust. For providers, they have different goals for different patients, and they should, based on level of sickness, based on type of patient, age, ethnicity, education level. To the extent that you can try and tailor your communication to meet your patient's specific needs, you're going to have better outcomes. So we can think about in terms of shared meaning, mutual influence, trying to talk to your patient and trying to build that common ground. You can ask a question, answer, try to stay on topic. Again, in terms of these concerns, for patients, they want to express their concerns. They want to focus on their story rather on their symptoms. Some other contexts, We have to deal with the media context, right? Because you've got patients that come in, you've got clients who they've seen this, that, or the other thing on the media. I want to wear these copper bracelets. Will those copper bracelets help with, this, that, or the other physical ailment? No, they won't. They'll turn your skin green, and they're going to cost a lot of money, whatever. But they've seen all this on TV. They've got this media influences. Maybe an organizational context. I'm a big executive where I work, so you need to listen to me. I know you're a doctor, but I'm also a big shot too. Or the cultural context. So how big of an impact does language play? Big time, right? Language differences? Oh, it's huge. And it's something that I could almost do an entire class in. Cultural background impacts as well. And stereotypes also impact. And then the political legal context. What role does communication play in malpractice suits? What do you think? How big of a role? Huge. Most malpractice suits can be avoided by forthright, proper communication. If you screw up, if there's an error, apologize for it. And when you apologize, say, here's how we're going to fix it. Something wrong happened. We know it's wrong. We're very sorry. It was a mistake. But here's how we're going to fix it. Most malpractice suits can be avoided just by that. There have been study upon study upon study that's shown that. When physicians get sued, when organizations get sued, is when they fall back on the whole, we did no wrong. The error was on your part, or something outside of our control, which everybody can smell BS with that, right? They're like, yeah, okay, right. No, I'm hurt, or something happened, or something worse happened. No, yeah, admit up to it. Something happened, something got messed up in a surgery. You can avoid being sued by simply admitting the error and also saying, here's how we're going to fix it, with a treatment plan to get beyond it. So what's the takeaway? I love acronyms. I think this should be somewhere in a handout too, I hope. This is the RESPECT acronym. 6 things you need to know. Build rapport. The smallest details such as physical appearance, your level of eye contact. How often you use their name in conversation to build rapport with patients. Explain. Ask patients a variety of questions that encourage them to explain more. Again, get them to tell their story. When they tell their story, that's when the important details come out. Show. Regardless of your specialty or practice, you will have to deliver constructive criticism and show them that you are empathetic, that you can help. And they talk about giving a 7-to-1 compliment ratio, for patients that are recurring patients. For every 1 criticism, try and give them 7 compliments on something they're doing well. In practice, the old adage rings true for a reason. Practice may not always make perfect, but the more you do this, the more you try this, the better you get. It's not a one-off. You may try it the first time, and it may come across really awkward and forced and weird because you've never done this before. Don't give up. The more you do it, the better you get. Practice does make perfect. Empathy. Avoid being judgmental because you don't know the full story. Like for that one diabetic patient who knew exactly what to do and wanted to, but couldn't cook for himself or wasn't able to cook for himself and wasn't able to get out and walk based on where he lived. Empathy, I think, is important there. He knows what he should do. His circumstances don't allow for it. But his physicians and his providers had been really kind of combative with him over the years because of all of it. They hadn't bothered to listen to his story. So they didn't know the context. Collaboration. Partner with your patients. Work with them. Identify barriers. That's important. Here's what you need to do. Is there anything in your life, what in your life is going to get in the way of that? How often do you ask that? Okay, here's the physical exercises you need to do. Here's this you need to do. How often do you ask, okay, is there anything that's going to prevent you from this? What within your life is going to make this challenging or hard to do? You'd be surprised how often they're going to list off a few barriers. And you may have answers to that. You may have suggestions for getting around those barriers that they hadn't thought of or they weren't aware of. Or maybe there's a resource they don't know about that can help them overcome that barrier. And technology. With a grain of salt. And this is based on comfort level. Some providers are cool with their patients or their clients emailing them. Some are not. So base it on your own comfort level. But if you're really cool and into technology and stuff like that, you're all Twittered up or whatever, pick one. pick a couple different technology. Okay, maybe you have an email account set up that's a secure email that patients can email you on. Or maybe you don't like that. Then don't do that. If they ask you to email, if they ask if they can email you, again, be honest. Don't get frustrated with them. Be honest with them about it. But to the extent that you can use technology, you'd be surprised how often you can avoid people coming in when an email could have answered their question. And that saves you time, and it saves them a hefty copay, right? Because if you've got to go on, I've got a $50 copay to go see Posey at SportsMed, right? I got the UK PPO, whatever. So I have this hefty copay. So I get big copay, I go on, and I could have been answered over an email. That makes the patient mad, right? And they leave there ticked off. Why did it, have to pay $50 to come in? Or maybe they don't have insurance at all, and it's several hundred. So again, technology can oftentimes help with a lot of this. That's all I got, folks.